clues of systemic diseases. Welcome, Prof. Ramam.
Thank you. Thank you for that wonderful introduction. Thank you, Dr. Mohammed and Dr. Nisha, for inviting me to the RADV and for accommodating my many requests in relation to the meeting and to when I would be able to speak. Thank you so much. I'm going to be talking about conditions in the skin that give you a clue to disease elsewhere. Most of the time when you have a disease on the skin, that's where the problem is. But occasionally you will have things going on in the skin that tell you that there is something else that is a problem that the patient is having. And these are familiar clues, some of them. So I want you to look at these 4 pictures and think to yourself, and if you're a little bit of an extrovert, you can shout out the answer. What do you think is happening in the top left panel there? That's right, I hear the answer. It is xanthomas. And because they are interdigital xanthomas, you can actually make a genetic diagnosis merely by looking at this clue. It's homozygous, familial, hypercholesterolemia, autosomal recessive. You can go that far just by looking at the skin lesions. What about here? Peutz-Jeghers. Once again, now molecular genetic diagnoses are available, but you don't need the test. If you have a dermatologist who sees this and is confident, that's good enough for the diagnosis. How about here? Yes, Fabry's disease, angiokeratoma corporis diffusum, and this is a little bit tougher. Oh yes, not for you, it seems. Yes, this is systemic amyloidosis, pinch purpura. So you have these situations, and many of these have been described. Entire textbooks have been written about them. But I'm going to talk to you about 4 clues that you may not have thought of as clues to a systemic disease. My first clue is the presence of ichthyosis in a child should make you think of rickets. It doesn't seem to matter what kind of ichthyosis the child has. In this case, it is epidermolytic ichthyosis, but it can also be lamellar or non-bullous ichthyosiform erythroderma. Here we have the hands of this child showing what is called the Mazeron phenomenon or variable verrucosity. And if you take, these are x-rays from the same child, and it shows widening of the growth plate, metaphyseal fraying, and cupping. And this is an X-ray of the child's hands, which show the same radiological findings, but you can also see the skin scaling forming bangles here at the wrist. Now, this was studied in greater detail in my department in studies that were led by Professor Sethuraman, who is the pediatric dermatologist in our department. And this is what we found. Now, whenever you hear about vitamin D deficiency and a skin disease, your brain switches off, because there are so many reports of vitamin D deficiency being associated with diseases. But this is genuine. And this is genuine because the children's bones are being bent by the disease. This is not some biochemical nonsense that everybody has. Of course, if you look at the controls, at the age of 6 months, about 1/3 of them have hypovitaminosis D. But if the child has ichthyosis, then 23 out of 29, which is 80% of children, have vitamin D deficiency. And in 19 of them, it is so bad that it can be diagnosed clinically or on X-ray. So this is a serious problem. Why, we should ask ourselves, in areas of the world where there is abundant sunshine, are these children getting rickets? Well, partly the reason is, I think there may be something to do with vitamin D metabolism, which is affected in children who have ichthyotic skin. Also, there might be, because of the stigma, they may not be going out as often as other children. But I think the more important question is, why is the diagnosis missed? Why do people come to us at these late stages of rickets? I think partly 2 reasons. One is, I think, when you see a child with ichthyosis and something else going on, you think it's syndromic ichthyosis, and you stop doing that. And for pediatricians, I think, though they are very good at diagnosing rickets, when they see a child with an extensive skin eruption, they said, go see the dermatologist. So what we are saying is that when you see a child with ichthyosis, most of us tend to think of another vitamin, we think of vitamin A analogs. We think of acitretin and isotretinoin. I am suggesting that we should first think of vitamin D. Think of the bones first and then of the skin, because dealing with the bones is easy. Dealing with the skin is a little bit more difficult. And this is all that you need to do. You have to make sure that a child with rickets is getting, with ichthyosis is getting the recommended dietary allowance of vitamin D. And if they have rickets, then of course you have to give them much larger doses, which can be even given high dose in either 10 days as we give in our department, or some people even give it all in one dose. One of the bonuses that we found when we were giving children with ichthyosis vitamin D is that the skin also seems to be getting better. This is a series of photographs from Professor Seturaman's paper, which shows that when the child at baseline and at day 21, there's a lot of improvement in the rickets. When I saw these pictures, I thought, is vitamin D also making them grow up very quickly? Because in 21 days, he's going from here to here. But I checked the dates, and they are right. So what is happening, I think, is that they are going closer and closer to the child's face to take the photographs, because the ichthyosis is less prominent. And that's why it looks like a big growth tonic also in addition. In fact, last year, a randomized controlled trial has been published comparing acitretin to vitamin D and finding that the results are similar in both groups of patients. So keep that in mind, vitamin D when you see rickets. So that was my first clue. My second cutaneous clue is something that I am going to show you, and I will ask you to guess. Now, some of you have heard this before, so please keep quiet. Let the others try and guess what this is, okay? So I'm going to show you a set of cutaneous ulcers, and you have to think, what is this systemic condition which is associated with these ulcers? And just in order to keep you going, I'll tell you what is the wrong diagnosis we made when we saw these patients. So this one, when we looked at, we thought, could this be pyoderma gangrenosum? When we saw this, we thought, atypical mycobacterial infection, maybe? But these are all wrong diagnoses, so you have to think of the right diagnosis. When we saw this, we thought, is this a sporotrichoid infection? Is it sporotrichosis? Here we thought, is this vasculitis? For this patient, we thought, could this be paniculitis? For this patient, we thought, is this hidradenitis suppurativa? And for this last patient, we thought, could this be stasis or arterial ulcers? But these are all the wrong diagnoses. And because I kept speaking and I didn't let you see these properly, I'll go back. So you can look at the images yourself again. One unifying diagnosis for all these ulcerative conditions. Okay, ready? The answer is pentazocine abuse. This is drug abuse. It's intravenous drug abuse and intramuscular drug abuse that is leading to this. The pictures I'm showing you is of this particular drug, but it doesn't matter. It can be any intravenous drug abuse that can lead to these ulcers. And here are the clues. You know, we tend to look at the big ulcer, but the clue comes from, look at these. These are sites of intravenous injection. Antecubital fossa, the wrist, and these show scars. Once again, let me show you the next one. Here again, we focus on this, but look, there is an ulcer here where this patient in the past has been injecting into the vein. Now, nobody injects intravenous painkillers or intravenous drug abuse in order to make ulcers. So this is not dermatitis artifacta. They are not doing this to get your attention. They do take the injections in order to get a high. It's just that the drug is so irritant that once the veins are used up because of the injections, it starts going into the perivenular tissue and leading to irritation and ulceration. Here the clue is the linearity, because it's along a vein. And here you have thrombophlebitis, which has subsided with hyperpigmentation. Here again, puffy hands because of lymphatic edema, because of blockage, and once again, the linearity. Here, if this is intramuscular abuse, if the person who is helping you with your intramuscular abuse is a doctor or a nurse, then you get these very neat ulcers and scars in that area. If you're doing it yourself, or it's a non-medical person who is giving you the intramuscular injections, then you get this broader, more bizarre distribution. So we've talked about some of these morphologic clues. Induration can be very prominent with this particular drug because it causes irritation, but these other features are true of all the others, or any intravenous drug abuse. But the more helpful question we find is asking, have you ever had pain? And what did you do for the pain? When you ask these questions, people will say, yes, 6 years ago I had a road traffic accident, and then I had a fracture, and I took some painkillers, but I stopped at that time. So this acceptance of previous use is reliable. The denial of current use is not reliable. And so again, if your house officer says that when I go to take a blood sample from this patient, it's very difficult to get a sample, that's a clue, because the veins are all blocked. And then if the patient is somebody who works in the healthcare industry, has a nurse who is a sister, or a husband who is a doctor, then again, this is a clue to the diagnosis. If you have access to urine testing, which we have in our hospital, then if you have to do the test for 6 days consecutively, because you can go for 3 days without taking the drug, but on the 4th day, your craving will be so high that you will take the drug. And so sometimes we will find that the first 2 samples are negative, but the subsequent samples are positive. And this is the most important thing. If you take a biopsy with a diagnosis of vasculitis, the report comes back as vasculitis, because there is something known as pseudovasculitis, which occurs beneath every ulcer. So if you make a clinical diagnosis of vasculitis, the biopsy comes back as vasculitis, then like us, you treat the patient for 2.5 years with corticosteroids, azathioprine, cyclosporin, and wonder why they are not getting better. And the reason they are not getting better is because they have pentazocine or intravenous drug abuse. And another thing to remember, this is a disease in which the patient is making every effort to keep you from making the diagnosis. They are hiding the facts from you. So you have to be careful. All right, so clue 3 of 4. Now you have facial pigmentation of a particular kind, which is a clue to the metabolic syndrome. This was not very well known about 10 or 15 years ago, but now there is greater recognition, and this is what I am meaning about. This has the pigmentation is typically on the sides of the face. That's why you have to take profiles. Unlike melasma, where you can take a picture from the front and show it to your colleagues in the audience, here you have to take profile. Here is another profile, pigmentation, little bit of darkening. Here is somebody, right profile and left profile, more on one side than on the other. But once again, you can see that it's on the side of the face. And here is somebody who has it on the right profile. And all of these are cases of? Absolutely right. These are all facial acanthosis nigricans. And if you have any doubt about that, you just have to see the same disease in a slightly more advanced stage, where actually the velvety change and the thickening of the skin is also coming in. At this stage, it's a bit easier, but as dermatologists who are used to looking at the skin and recognizing signs, I think we should try and identify it at this stage. Also notice many of them have quite plump features, which is why we said that you have to look for metabolic syndrome. If you have some doubt about whether the patient has facial acanthosis nigricans or not, you might want to look at the neck, but that for me doesn't work very well. Most of the time, you have to get them to take off their shirt and look in their axilla and then see the acanthosis nigricans. This is because he's put some talcum powder in his axilla, but that's the acanthosis nigricans. The other thing as dermatologists I think we need to remember is that depigmenting agents are very unhelpful in this group of patients. If you use hydroquinone or triple combination, maybe for a little while he may feel a little better, but weight reduction and lifestyle modification are key, and you know how difficult it is to make people to do that. I think this is a little extra motivation, vanity, can make you do things that you would not do otherwise. So if you say you will look better if you do this, maybe people will accept your advice. And I can testify to this. I have patients who have come back to me after 3 months, having lost 12 kilos and having less pigmentation on their face. All right. My last clue is that if you have insect bite hypersensitivity that occurs later in life, think of an immunocompromised state. What do I mean by insect bite hypersensitivity? This is something that's also called papular urticaria or exaggerated insect bite response, and it usually occurs in children. Look at how sad this guy is. Okay, if you have to take a picture, take it, but can you get the mosquitoes to stop biting me? And fortunately, as time goes by, this goes away. Another clue is the waistband sign that you see in these children. So sometimes this gets mistaken for atopic dermatitis. Sometimes it gets mistaken for scabies. I find this a very helpful clue. This is the part of the body where the clothes on the upper part go up and the lower part go down. And so this gets exposed and mosquitoes come and bite there. So I call that the waistband sign of insect bite hypersensitivity, which is all very well. But if you have somebody who is in their 20s and who for the first time is getting insect bite hypersensitivity, this child turned out to have, I should say adolescent, this adolescent turned out to have HIV. In fact, this was a study we did in a group of patients in HIV in Chennai, and we found that what is called the papulopustular eruption of HIV is actually in a large majority of patients just late onset insect bite hypersensitivity. And this is not just something we have found across the world. There are studies from Africa also which show that insect bite hypersensitivity can be a manifestation of immunocompromise. And that brings me to the end of my presentation. I will leave you with a visual summary of the clues we've talked about. When you see a child with ichthyosis, think of the bones. Make sure they're getting enough vitamin D. If you see ulcers that are bizarre and difficult to explain, keep in mind the possibility of intravenous drug abuse. Metabolic syndrome, facial acanthosis nigricans may present like a pigmentation. Don't treat it like a pigmentation. And if you have late onset insect bite hypersensitivity, think of immunocompromised states. And I want to end by thanking Dr. Ria Ahuja of my department. She's a senior resident who helped me to put this presentation together. And I thank you for your attention.
Thank you, Prof. Ramam, for the excellent presentation, beautiful pictures and clinical clues. We have 2 minutes for questions.
Super excellent presentation. Thank you. Well done. I have 2 questions.